Hey guys, so I'm Dr. Oob. I've got my little brother, Dr. Oob, here, and I'm in Austin, Texas. He's in,
Baton Rouge, Louisiana.
okay. And so we've already had one discussion on random things on how Baton Rouge is going and all that, but he's my leading expert as far as what COVID-19 is doing to the heart. He may not like being my leading expert on what's it doing to the heart, but not a lot of people are talking about this, Robert. So you were the first one to mention you had this STEMI patient. So give me
hmm
the spiel. What's going on with COVID-19 in the heart?
Yeah, so to summarize what a STEMI is, the way I explained it to a friend earlier today was essentially when you can see someone's having a massive heart attack, we can see it evidenced on an EKG or electrical study of your heart. There's kind of a very obvious pattern that says there's significant lack of blood flow to the heart. It looks different than maybe other milder heart attacks. So this patient came in with clearly having one of these massive heart attacks or STEMI. Um, uh, for those medical people, is inferior lateral. So, but very obvious, very classic SD elevation in the inferior lateral lead. So, um, this guy was found down. Presumably, I believe he was intubated on arrival. But what made us suspicious for COVID was that he had presented 3 to 5 days, I forget, about a week maybe before, with classic COVID like symptoms, flu-like symptoms, etc. He was swabbed for COVID, and then at that time he had no criteria for admission, so we let him go back home to quarantine by himself.
Really?
Like I mentioned in the other video, this was one of those guys who lives alone, doesn't have much contact. It was actually a family member who hadn't heard from him in 3 days, called EMS to do a wellness check and found him down on the ground. The door was unlocked, so they were able to easily come in. And so they brought him in. He was a STEMI on arrival, so they brought him to the cath lab and had completely clean coronaries or heart vessels.
Really? So
Completely
see, that
clean.
was the part I hadn't heard from you yet. Completely
Yeah,
clean arteries, yet a
right.
fully blocked artery. Because in order to have a
From what
STEMI, you've got to have complete blockage of an artery.
right, right. And yeah, and so to explain to some of your audience, non-health professionals, so a heart attack, a classic sense of a heart attack is whenever you have a blood vessel that that provides blood flow to your heart. The classic sense of a major heart attack is when you get a clot or a thrombus that plugs up that artery, and that's when you get a major heart attack, and that's usually the kind of stuff that we see leading to that kind of appearance on an EKG. So that's what we were expecting, and that's not what they saw.
So, well, so if they had completely clean arteries and none of them were clamped, are they suggesting that this was a myocarditis, inflammation of that part of the heart?
That's what we're thinking. So in myocarditis, is inflammation. I guess breaking it down, myo is muscle, cardio is heart, and itis is inflammation. So it's inflammation of the heart muscle. Whenever we see that appearance on the EKG, it suggests that the entire wall is infarcting or dying. Um, I think so. That was the assumption, that either there's so much inflammation from the myocarditis that maybe it's causing the blood vessels to swell, and they're clamping down on these very, very small blood vessels. There are some, we did a cardiovascular grand rounds this morning. There was maybe some suggestion of maybe these patients were hypocoagulable or increased risk of clots, and maybe there's some micro clots happening at a microvascular level causing this appearance.
But they didn't find any clots that they could either
Nothing in the major
angioplasty or put a stent in.
Nothing.
And did this guy, so whenever you have that much heart tissue damage, you've always got what we call troponins and cardiac enzymes in your bloodstream. So I assume this guy was emitting tons of cardiac enzymes. Did they spike and fall, or was it prolonged?
I don't think we had enough time for it. I think his troponin was elevated on presentation.
Oh, he died?
Yes.
Oh, I was missing that part of the story.
Yeah.
Well, no wonder you don't have a trend of how they went up. So
right,
they just went up. Okay.
So yeah, it was positive. It was elevated. But from what I heard, he unfortunately right after catheterization didn't last too much longer.
Yeah, that sounds pretty fishy because STEMIs, yes, they can kill you, but STEMIs, if
Yeah.
you can get them to the cath lab, usually you can pull them out of it.
Right. But how long was this guy down? Was he hypoxic for hours on end? It's hard to know.
Right.
But my initial assumption when I heard this case was, the guy was just hypoxic and he was infarcting his heart. That was my initial assumption. But it sounds like it might be a little bit more than that, especially because we're hearing more and more that there's an associated cardiomyopathy maybe going along with this illness. And is this related? You mentioned myocarditis and pericarditis. There's a virus that we all learned about in med school, Coxsackie. Is it a similar mechanism? We don't know.
So for people that don't know, Coxsackie is a common virus that we're taught in med school that loves to infect the heart. And when it infects the heart, it can shut it down. And usually people live through it as long as they get the adequate treatment. But there's only so much we can do to replace heart tissue, or not replace heart tissue, but replace heart function. We're not that great at pumping blood for you. There's LVADs and stuff, but when you're on that, you're not looking so good. But the whole line, when you first mentioned this whole STEMI thing and myocarditis, pericarditis thing, those are just fancy words to say any inflammation of the heart tissue, the sac around the heart. I started thinking back, and all of the patients that I have that are suspected COVID, every single one of them complained of chest pain at some point in the course. And it's not, my patients are very mild. Everyone survived. No one's gone to the hospital. So it immediately made me realize that when people tell me chest pain, everyone always directs it. Well, not everyone, but most of the time they direct to the center of the sternum, the center of the chest. And it feels tight, it hurts, it aches, whatever. And I just assumed, since this is a lung-eating virus, that I just assumed this was the lung tissue that was inflaming. If you've ever had an influenza or bronchitis and you're coughing, it's achy in there. But one of the things you can't differentiate is lung pain from heart pain. That's one of the reasons we call this referred pain. When you have chest pain, you feel it in your arm, you feel it in your shoulder, you feel it in your jaws or whatever. What people don't understand is our internal organs have very poor sensation. If I unzip your chest, just unzip you, and I start stabbing you in the heart with a knife, you're going to be like, I don't feel good. I have arm pain. My chest kind of hurts. But if I stab you in the arm with a knife, you're going to say, you're stabbing me right there with a sharp object. I know exactly where it is. I know how much it hurts. I know how big the knife is. And so our internal organs don't have that great of sensation. So you can say chest pain, and I can't differentiate from the outside whether it's your lungs or your heart. And there's no real good heart test until you've done enough damage that you can start seeing that stuff. But in general, as far as signs and things that people should worry about, Robert, if it is progressing to this point, you would think that there would be some warning signs beforehand, right? The sweating, the shortness of breath, the fatigue, the as you mentioned in the last video, like how far can you walk? If you can't walk out of a room without getting shortness of breath, I think it's time to go to the hospital.
Yeah, and generally, what I was listening to Society of Hospital Medicine podcast this morning, and most of this is a late finding. So normally, and again, my assumption is this guy was probably very sick before he developed this. Again, he was unobserved for 3 or 4 days, right?
But that's still kind of scary, right? You were in the hospital 3 or 4 days before, and now you're dead. Right. So what happened in between that he didn't seek care is the scary part.
Right.
He wasn't holding his breath. I can guarantee he wasn't doing his breath holding test.
Yeah. But I mean, what I think this whole cardiomyopathy pictures they're seeing is a late finding, like that even if your respiratory symptoms will come and go, and then this is a later finding. Again, it's so early on. This is, I don't know if we can say for sure one way or the other, but that's not initially what I'm hearing. Is it's a later finding, not a presenting finding, but I think it's just too early.
Okay.
Yeah,
that's absolutely fascinating. And I hope you guys write a case report or something on it, because I haven't heard anyone else talking about COVID-19 affecting heart and blood vessels and things. But at the same time, It's an inflammatory process, right? You've told me before that when you're checking these people's CRP, which is an inflammatory marker, you're doing a regular CRP, not even the high sensitivity CRP, and these people are blowing that off the chart.
Mm-hmm.
And so it makes sense that you inflame the body enough, something's going to go wrong. And this guy just had the bad news of it affecting his blood vessels and dropped him.
Right, right. And that kind of leads into a discussion about Plaquenil and azithromycin, if you
Give us
want
your
to.
take. Yeah,
That's
go
going to
for it.
be um, essentially where we're at as a group. We had a meeting today about this, and pretty much it was a, hey, you just decide on your own. Nobody can make a blanket statement about this right now. The CDC hasn't. I think I heard rumors that maybe they're going to come out with some guidance against it. Um, Personally, what we're doing in the hospital, it seems to be what everybody's doing is we're not starting it on the patients who are not intubated. Once they get intubated, um, the last I heard is our ICU doctors were starting Plaquenil and azithromycin. Um, uh, I think I've seen 500 milligrams twice a day. I think what our doctors are doing are 400 daily. Um,
Yeah, it's
why are you shaking?
usual. It's 200 milligrams twice a day. As far as the study I looked up,
Yeah.
for Plaquenil, and for people who don't know, Plaquenil is the same thing as
Mm-hmm.
hydroxychloroquine. Hydroxychloroquine is the precursor to chloroquine. So everything you see is chloroquine. No one freaking uses chloroquine. Everyone
Mm-hmm.
uses hydroxychloroquine, which is Plaquenil. I'd much rather say Plaquenil than hydroxychloroquine.
Yeah.
So the dose I read from the study was 200 milligrams twice a day, which is the normal dose we use in our autoimmune patients anyway. And then azithromycin, same thing, the normal dose we use for bacterial infections.
Mm-hmm.
500 milligrams the first day, 250 milligrams for 4 more days, and then you stop. The big question I want to know is, and everyone's wondering, I don't know if you have a take on it, is so I'm telling people, wait, don't take it, because if you have a mild case, that means you're going to contribute to the shortage. And who knows, maybe you didn't need it, maybe you did need it and it worked.
Right.
But what if we wait too long and then by then it's not useful? Where's that right time to start it if we're going to use it?
I think nobody knows. I mean, and I think that's why there hasn't been a guidance on it one way or the other. A lot of anecdotal uh, evidence. There needs to be a study on it. I'm sure somebody's doing it right now.
Well, there's plenty of patients to study. So.
Right, right. Um, but I kind of lost my train of thought there. But
One of my patients even suggested, he's one of my COPD patients. He's like, I briefly thought about enrolling in one of these studies and saying, give me the virus and I'll take the drugs and you can study me, but I'm getting the drugs, so I'm happy. And if I
right.
don't do well, you're required to treat me because, well, you infected me. So, and I
Mm-hmm.
was like, I don't know if that's a good idea.
Yeah, I mean, I think we were kind of leaning. I think everybody was kind of leaning towards, oh, yes, let's go ahead and use it. But as we've had more and more, the reason why I kind of use this as a segue to this is as we're seeing more and more of this rumors about this cardiomyopathy and ventricular arrhythmias, or the heart going into an abnormal heart rhythm after the respiratory problems. So Plaquenil and azithromycin both prolong the QTC. So for your
Oh,
yeah, so for your audience, so every time the heart beats, there's electrical shock that makes it beat. Just like a battery, it's got to recharge. So when it beats, it recharges. There's a period as it's recharging that the heart is very susceptible to go into an abnormal heart rhythm. So the longer that recharging period is, the more likely the heart is to go into these maybe fatal heart arrhythmias. Both Plaquenil and azithromycin prolong that repolarization or that recharging of the heart. So as more and more evidence has come out that these patients are having arrhythmias, and sometimes after the respiratory problems have resolved or getting better, that's, I think, made people a little bit more wary about using those medicines.
interesting.
So
So it might save your life from COVID. You might drop dead.
exactly.
Hmm.
Exactly.
All
So
right.
So it's literally a in our group right now. It's a personal decision. Whatever each physician, there hasn't been guidance for me. What I probably are not, we're not going to use them. The only thing that we have shown that has helped these patients decrease mortality is supportive care, and that being supplemental oxygen, ventilatory support if needed. That is the only thing that's been proven. So
I'm glad to hear you
we
say that,
yeah
Robert,
we
because I think
yeah
people in America, we're so used to popping pills, and not we, but other Americans are so used to popping pills and relying on the pharmaceutical industry for everything. And one small study, but not enough data comes out suggesting hydroxychloroquine and azithromycin, and now the whole nation is trying to hoard it and see
mm-hmm.
if they can have this life-saving medicine. And we can't forget that just a simple ventilator goes a long way. The problem is there's not enough ventilators to go around if everyone
Mm-hmm.
gets sick right now. So
Mhm.
keep practicing the social distancing and try not to get the virus. It's my assumption that almost everyone on the planet is going to get this virus. Its high estimate is 75%. It's a likelihood that you're going to get it. But the most important thing you can do is delay, delay, delay. Because every person that gets it, they likely infect 2 to 4 the next. So if you can stop
Mhm.
that by isolating, we can try to limit how much we overload the hospital systems. Based on where I'm sitting and what I'm looking at and the numbers, we're already going to overload the system. We're in exponential growth and we didn't stop it soon enough. Now, I think our isolation has helped and it will slow the curve eventually, but based on how fast we're going, we're already going to overload. Just let's
Mhm.
hope we don't overload too much. There will be unnecessary deaths, in my opinion.
And what we don't need is a bunch of lupus flares coming to the hospital because they can't get their Plaquenil, right?
Yeah, that's so true.
um, so because I keep talking and thinking about all the indirect morbidity or deaths that will happen due to COVID, but indirectly because what somebody ran out of Plaquenil. People probably aren't going to die without their Plaquenil, but
Well, no, I mean, think about it. You actually can because
yeah,
Plaquenil, luckily, it's got a long half-life, right? Half-life
mhm,
is 30 to
right,
52 days or something like that. So when they run out, they've got some coverage. But now they have to take steroids to help cover for the lack of Plaquenil.
right,
And now you're on steroids, and your risk of getting COVID and dying is higher because you're on steroids. Um,
hmm
and so or what worse, they can't even get steroids because that's on shortage because of all the asthma people going through COVID. So yeah,
hmm
it's a fallout that could literally harm people, and we can't ignore
hmm yep, exactly.
that. All right, well, fascinating discussion, Robert. Let's end this video here on the cardiovascular stuff, and we got a little off topic, but that's cool. Great, thanks for
All
your
right,
contribution,
yeah,
Robert.
thanks for having me.
Good.